Hello. You hear me? Okay. So anyway, my topic today is like non-IBD colitis, and so it's a definition. It's essentially anything other than ulcerative colitis and Crohn's I'm going to cover today, and like simply miscellaneous. By definition is various pathological conditions that are similar in clinical presentation and endoscopic appearance, just like IBD, but they are by different etiologies or clinical courses or peculiar histological features and treatment. And it's again, like just like Cassandra was saying, like a history. Like you talk more, if you sound like fishy, if it doesn't look like UC or Crohn's, like just talk to the patient, they will tell you the answer. And the review of medications is very, very important. Like we'll go over this. And like if there is a pathology results comes back as like questionable IBD, so look for these two important words. Features of chronicity means like crypt distortions, and that's essentially like branching and irregularities in the size and the shape, and basal plasmacytosis. If you don't see those things, like probably it is not an IBD. So there's a few conditions that I'm going to go over. Let's see how much I could cover today. And again, like first topic is microscopic colitis, but to be fair, it is actually an inflammatory bowel disease. So it may not even come under non-IBD colitis, but again, nobody covers this, so I'm just covering this. So it's not fair. So let me go over like a couple of slides. And so you need to have three things to call this as a microscopic colitis. One, patient should have a chronic watery diarrhea. So it means we are not talking about patients coming with, yeah, I have like 2-3 days of constipation, then followed by like 2-3 days of like 3 bowel movements a day. That's not how they look like. So they usually have like profound diarrhea, like 8 to 10 bowel movements a day or more, waking up in the middle of the night. So you need to have that. Then colonoscopy looks like normal or near normal. Again, Cassandra touched on that. It's like there are, if you clearly, like if with the higher definition colonoscopies, you can see some subtle changes. And in fact, if you're putting like a lot of air, and you can even see some of those like air artifacts. And then, of course, this is more like a pathologist will confirm you that this is like a pathology diagnosis. And again, in a true population of chronic diarrhea, this diagnosis, microscopic colitis, could be as high as 12.8%. And they are female predominant and like in their 50s to 60s. And there is a 5% overlap between between microscopic colitis and celiac disease. So if you're having a microscopic colitis patient and you're treating it appropriately, and if they are not responding, and look for celiac disease. There are two major components or major subtypes. One is collagenous colitis, and the other one is lymphocytic colitis. So you may see. Yeah, you can see a band here. This is like an increased subepithelial collagenous band, and the thickness should be like more than 10 microns or micrometer. And there's a lymphocytic colitis. You can see here, it's like a lot of lymphocytes, and technically the pathologist will count is like it's more than 20 lymphocytes among the 100 epithelial cells. And there is a subtype, it's called like incomplete, when the criteria that you cannot meet that number. So it's essentially half of the numbers. So 5 microns, but less than 10. And or intraepithelial lymphocytes of more than 10 or less than 20. So that's called incomplete MC. Okay, so let's go, like I know it's the last session, so I'm gonna just I can see a lot of you all yawning, so I'm gonna ask you some questions. So it's like, this is a 68-year-old female, like a typical, coming with like a 3 months history of watery diarrhea. And she is on omeprazole, aspirin, amlodipine, and ibuprofen. Okay, so we did the review, and then also she's a smoker. And she has all the stool, you guys ordered the stool test, GI, PCR, all those things negative, and thyroid celiac panel negative. So you are ordering the patients in for colonoscopy, and the pathology comes back as like microscopic colitis. So what would you do next? So would you advise? And this is where you guys come in, right? So most of you might see this kind of patients. So what would you do next? So would you advise stopping the medicines, like the offending medicines, like PPI or the NSAIDs, and reevaluate in 6 months? Or how many of you would do that? Or like advise stop smoking and come back in 6 months? Okay. Or ask them to, okay, let's go for a EGD and do a celiac disease ruling out, like by biopsies. And start Imodium and just like cheap and best and try that. Or directly like go full throttle, like go for a budesonide 9 milligram. So, okay. So let's go why it's not right. So the number of bowel movements, if you see that patient had like 8 to 10 bowel movements. So if you have symptoms mild means less than 3 bowel movements a day, then you can try Imodium. But if you're going more than like 3 bowel movements, that means severe, and microscopic colitis, you go for budesonide treatment. But you can do other things too, like you can ask the patients to stop smoking, and the offending medications can be stopped if possible, but oftentimes may not be possible. For example, like PPI, NSAIDs, statins, ACE inhibitors, everything can cause, but you can't stop all of them. And let's go like one more slide. So it's again like when would you do the celiac panel and all? Again, like so the algorithm like sorry, just better. Okay, so if it's the algorithm is like first you treat with 9 milligram of budesonide for 2 months. Then if the patient responds, then you taper and discontinue in the next 4 weeks. But if it's not, if the symptoms are coming back with the relapsing, then you treat with a lower dose, like 6 milligram, and over a period of 6 to 12 months. And if the patient getting better, that's fine. But if the patient is not getting any better, then you look for celiac disease or extended workup. And also you can even try for looking for medication stopping and smoking and alternative treatments like even anti-TNF agents. Okay, so screen for celiac disease, very important. And you don't need a serial colonoscopies to check for whether the microscopic colitis is gone or not. So the one important thing is clinical remission target that is something more defined now. So before there was no target. Now you don't need to check for calprotectin. You don't need to do another colonoscopy to see whether the band is gone or not. It's more like a clinical target. If the patient is doing less than 3 bowel movements a day, that means that's fine. And okay, let's go for a second question. So 45-year-old healthy female, you're sending her for a colonoscopy. And no symptoms, but the colonoscopy showed few arthritis in the terminal ileum and the cecum. And there is a diaphragm-like structure in the ascending colon. What do you think it is? Anybody? Okay, so this is drug-induced colitis, okay? So anybody knows what drug it is? Okay, it's NSAIDs, right? So it's common, like very common finding of like creating a diaphragm-like structure is very, very common. So it is a drug-induced inflammatory colitis. The list is long, and a lot of drugs we use itself can cause inflammatory colitis. And among that, the three things that I want to touch base with, one is NSAIDs, like at least 70% of the patients with inflammatory colitis from the drug is at least like related to NSAIDs. And the common manifestations are like some athos ulcers in the TI and the right colon, and it could be having a peculiar diaphragm-like structure in the right colon. Mesalamine, there are 5 to 13% of the patients, once you start UC patients on mesalamine, they paradoxically get worsened. So that is again, drug-induced inflammatory colitis. It is an idiosyncratic reaction and the exacerbation of the existing inflammation. And MMF, so we have a very robust transplant team at Baylor. So we have seen tons of MMF patients, like a mycophenolate patients comes with diarrhea. This is one of those most common symptoms that warranting withdrawal of the drug. So drug-induced microscopic colitis is a little different. Again, we touched that briefly. So PPIs, SSRIs, and NSAIDs, and beta blockers, statins, like a tons of list. So again, if possible, the medication can be stopped. Then drug-induced ischemic colitis, again, that is very important, like laxatives and antidiarrheal medications and digoxin, OCPs. It's a long list. So drug-induced colitis, I usually do, that's how I separate them, inflammatory colitis and microscopic colitis and ischemic colitis. Then one last word about ICI colitis. It is like an immune checkpoint inhibitor colitis. Again, like our program had a big oncology program, so 16% of all the oncological patients are getting this newer class of medication called ICI drugs or immune checkpoint inhibitors. And there are three major subgroups or like categories, like anti-CTLA4 and PD1 and PDL1. So what are these? Essentially, like how I imagine is like you have a tumor cell and a T cell, and like imagine they are boxing, right? So you're just holding both hands so you can't fight. So that's what this inhibitory checkpoint molecules. So the inhibitors, these newer medications, essentially like taking one hand off so that you can punch. So that's exactly what these medications are doing. These medications are very common now. So drug review of medications is very, very important. And usually the oncologists are very good in treating this ICI colitis because they know. And if they are sending the patient to you, so it's essentially for colonoscopy. So we use the CTCAE version 5, that is common terminology criteria adverse events. That's how you classify that. So how do we grade these symptoms, or how do we grade the ICI colitis? So grade 1 means comparison to the basic, like their baseline bowel movements. If they have 1 or 2 bowel movements a day, and if he's having like 4 bowel movements a day, that means that's grade 1. If he's having like 7 bowel movements a day, that means probably like grade 2. If it's like 10 bowel movements, it's like how much more from the baseline is where you calculate. So you grade them. Then you go for the management option algorithm in the next slide. So one thing is, usually oncologists are very happy if they are starting this medication and the patients are getting a colitis symptom. They are usually happy because the medicine is working. So, but if it is overdoing, then of course we have to treat it. How do we treat? So before you start the medications or prednisone, you do a Flexig and colonoscopy, and for all patients with a grade 2 or above, you do Flexig or colonoscopy and take biopsies. Because there is a small entity and there is an ICI colitis or ICI microscopic colitis is a different entity. So not all ICI patients having a diarrhea is not ICI colitis. It could be a microscopic colitis. So you have to do a colonoscopy and do a biopsy first. Then it could be sometimes patients getting a PET scan for something else, and you can see like lighting up. Like, so if this patient had a PET scan, you can see the entire colon is like lighting up like bright. So if the symptoms are not that severe, you don't need to address this. And so how do we treat? I don't know, it's a pretty small word, but so I'll just go over here. So grade 1 symptoms, it's supportive care. So you just, you don't need to stop the medication. So, and you just give some IV fluids and continue the ICI. But grade 2, you stop the ICI briefly and give them a prednisone. And then if they are doing well in 72 hours, it's very important. We are talking about stopping the very important medication for their cancer. So if you are holding the ICI and you're giving a prednisone, it's a big deal. So within 72 hours, if the patients are getting better, then you just taper and discontinue the steroid over a period of 4 to 6 weeks. If they are not getting better, then you admit the patient, give IV hydration, give IV steroids, and may even need anti-TNF agents. Same thing for grade 3 and grade 4. So you probably start with IV fluids, hospital admissions, and if they are not getting better by 72 hours, think about biologic drugs. So biologics, there are 2 drugs that are approved or kind of approved, or small clinical trials, or like either infliximab or vedolizumab. It's a standard regimen. So you just give them 1 dose, you will see the improvement even like within 48 to 72 hours. hours. But sometimes you may give like a full induction course. And there are some small clinical trials are saying like a Vedo is better than infliximab, but so far I have like 7-8 patients, and usually Remicade works. And should we restart the ICI? If the grade of the symptoms are like more than 3, then probably the same ICI should not be started. So it's probably one question they might ask. Okay, next question. So this is a 58-year-old female, comes with 3 months history of intermittent constipation and diarrhea. So you're sending that patient for all the workup and $1 million workup, everything negative, going for colonoscopy. So this is what you see. This is, anybody names what it is? So this is pseudomembranes, right? So these are pseudomembranes. And then you're going back and check, okay, the C. diff is done or not. Yes, this patient had a stool studies already done, and it is negative. So what should we do? So you order a repeat C. diff with maybe a different test, like a PCR, or just stop advising, stop smoking, start with PO vancomycin, and use a CT angiogram, and a review of medication, stop NSAIDs, and reassess in 6 months. PO. Okay, so what is this condition? C. diff? Let's see. Okay, so this is pseudomembranous colitis. So again, what are pseudomembranes? Essentially, it is volcanic-like eruptions. You can see like endothelial damage that impaired blood flow and decreased oxygenation. All this ischemia, it is causing the inflammatory cells, and mucus is coming out. So you can see those things here, like volcanic-like eruptions. So all these are like white things. So this is very important. Like most common cause of pseudomembranous colitis is C. diff. That's 90% of them. But the reverse is not true. So only 10% of the C. diff can cause pseudomembranes. So if an initial C. diff test comes back as negative, then probably look for alternative etiologies. So you can have various other infections apart from C. diff. There are other bacteria that can cause. Other inflammatory conditions can cause, like I had a patient with ischemic colitis who had pseudomembranes. And then the drugs, like this patient was taking diclofenac, and this is drug-induced pseudomembranous colitis. So look for alternative etiologies. Okay, so if the first set of 2-staged C. diff test is negative, then repeating the C. diff test, the yield is only 5%. And if at all positive, it is like probably a false positive. So I would not repeat it. Okay, so just because we touched the C. diff, I'll just go over a couple of things. So you guys all know about C. diff. I'm not going to go into detail. So you know the grading, non-severe, severe, fulminant, and recurrent. And so the 2-stage testing is very important. So first you go for EIA for GDH first. That will test for both toxigenic and non-toxigenic strains. And that has a sensitivity of 100%. So it's usually initial screening test. So if it is positive, it goes for EIA for toxins A and B. So this is more like a specific test. And that is having a lower sensitivity but a higher specificity. But the only important thing is like make sure that patient is able to drop the stool within 2 hours, and if not, should be stored at the refrigerator. And the ordering GI PCR or the polymerase chain reaction, those tests, it has a caveat because it is a good sensitivity and specificity, but it cannot differentiate between the carrier state versus true infection. So again, as I told, like do not repeat test if one C. diff test is negative. Okay, there are tons of guidelines came, ACG in 2021 and IDSA in 2021, and there is a ESC MID like 2021. So all of them are saying that fidaxomicin or vancomycin is better. Rarely anybody is using Flagyl nowadays. And there's one thing that I want to touch base is like Zinplava, which is like one of those humanized monoclonal antibodies against the C. diff toxin B, so which we give one dose during the initial treatment. So which patients would you give? There is a risk, so risk stratification is important. So if the patient had at least 3 or more risk factors in this, like antibiotic use, advanced age, hospitalization, severe comorbid illness, enteral feeding. So it's done, like there's 11 different risk factors they identified. Among that, if you have more than 3 risk factors, so one dose of Zenplova will lower the recurrence rate by 25%. Okay, because of the time, I'll just skip some other topics. So one other thing that I want to briefly touch is like C. diff in IBD patient. So it could be 2 different things. So you may have inactive IBD with a true C. diff, or an active IBD with C. diff colonization. So it's very difficult to differentiate those things. So what you do, like how would you treat these 2 patients? So if you have an inactive IBD with a C. diff, is you just treat like a regular C. diff patient. So you just treat the C. diff and the patient will get better. And if that doesn't get better, like look for alternative etiologies. But if you have an active IBD patient, like active UC flare, hospitalized patient, C. diff come back as positive, so which one would you treat? Like, so you start with PO vancomycin, but within 72 hours, if no improvement, so you escalate the therapy. If the patient is already on IV methylprednisolone, go for Remicade or maybe like alternative drugs. Okay, next question. So patient had a diverting colostomy 1 year ago for perforated sigmoid colon. So now comes with bloody diarrhea from the rectum, not from the ostomy. Ostomy looks like clean. What is this condition? Anybody knows? So you're doing a colonoscopy through the rectum. That's what you see here, like severely inflamed colon, where all this, the entire area from here to here looks like severe inflammation. And you also insert the colonoscopy through the ostomy, that looks like completely normal. What is this called? Okay, so this is called like diversion colitis. So very simple, like it is the colonocytes eat or get their nutrients from the stool. It's essentially the short chain fatty acids is what they eat, but at least 70% of their nutrient comes from that. So when you're diverting all the stool and the like defunctionalized or bypassed colon segment, they can go for inflammation. And so it could be like, it could be mild, moderate to severe. And so the one thing is, like, if possible, the treatment for this is like restoring the intestinal continuity. So if in this patient, we refer the patient to surgery and they can reconnect, and that's going to resolve. There are some patients you cannot reconnect, and and those patients, like, you can go for this like short chain fatty acid enemas. It's very difficult to get. So it's I have tried like probably like I got like twice after trying like 20 times. And so topical mesalamine or even anti-TNF agents can be tried for those patients. Okay, next question. So there is a 62-year-old female who had a stroke recently, and she is in the nursing home or rehab, and she was sent from the rehab to the hospital for bloody diarrhea for 3 days. And a colonoscopy was performed. There is a large ulcer in the rectum. Or what is it? Correct. So this is called like solitary rectal ulcer syndrome. It is a misnomer, like because only one third of the patients will have single ulcer, and at least 25% of the patients will have like more than one ulcers. Previously it's called as stercoral ulcers, but now it's like SRUS. It's a short version. And usually by ischemia, this is the pathology is very important. Like there's a rectal prolapse or intussusception along with the paradoxical contraction of the muscle. So it causes a mucosal ischemia. So the mucosa sloughs off and patients bleed. So the treatment is like usually if the patient cannot like go back to a regular life, like for this patient, stroke patient, right? So it's like then we had to do other workup like dephagography or MRI dephagography can be done. And initial measures are usually like a bowel regimen and kind of biofeedback technique, and sometimes surgery might be needed. Okay, so this one, I believe it was touched in the morning already, so I'm going to skip it. Okay, so this is a 65-year-old patient, like vasculopath. You have a patient had a coronary artery disease, diabetes, hypertension, peripheral arterial disease, TIA. So it's like all the vessels are like having an issue. Came with vague abdominal pain and one large bowel movement with a bright red blood. And CT was done, and then, so I had patients came as an outpatient like this. So usually they do the CT scan, and it's like, yeah, you have a left-sided colitis, and you probably have ulcerative colitis, go and see an IBD doctor. So I have tons of patients who come like 2 to 3 weeks after an ER visit with a left-sided colitis, and they come with, yeah, I have a Crohn's disease, that's why I'm seeing you. So it is not IBD, so it is, what is it? Yeah, it's ischemic colitis, right? So colonic ischemia, so it's like previously it's called like ischemic colitis, now it's colonic ischemia. So the one thing that you need to do all those things is like there is a risk or grading, or so these are the risk factors. So if you have at least more than 3 risk factors, it's called like severe. So those patients need like more workup. So most of the time these are self-limiting, and they usually resolve by the time they come to you. Their symptoms are already gone. Some patients can be like still symptomatic, but most patients when they see you as an outpatient, they already better. Any APPs doing an inpatient, so you probably see them as the same day. And do they all need a colonoscopy? A quick one, just go and have a quick, I'll show here. So there is of course the patient need a CT and early limited colonoscopy. Just go and have a quick look and take a biopsy and confirmation and come out. So all we need is like a few days of antibiotics and supportive care. There are some patients, if this is full thickness colonic ischemia, might need a surgery. Okay, so one more topic maybe. So this is a 72-year-old male with a prostate cancer requiring a treatment 2 years ago. Came with rectal bleeding. What is that? Okay, so this is also like we get quite often. So this is a newer name for this. So it's called like RICAP. So radiation-induced colitis and proctopathy. So acronyms, right? So there's a different things. It's like acute radiation proctitis means like within the few days to weeks. And chronic ones are either, it's called like a RAVE or radiation-associated vascular ectasia, because you have inflammation in it. So when you have no inflammation at all, that is called like chronic radiation proctopathy. So the treatments are like slightly different on that. So this is radiation-induced proctitis. So this is acute. So this is how they look like. So like looks like ulcerative colitis or proctitis, and they bleed. And they usually have incontinence, pain, rectal urgency, and mucosal discharge. So usually it's like for treatment for this is essentially like sucralfate and some like symptomatic management. But the chronic ones are usually need some treatment if it is bleeding. So you go and do, so you have a RAVE. If the usually the RAVE patients are bleeding from those vascular ectasias. So we do and burn it during the colonoscopy. And chronic radiation proctopathy is more like a lifestyle changes. Okay, so these are chronic change. So it's more like history. And I would stop here like 4 o'clock. So, any questions?
Thank you, Dr. Subramanian. Does anybody have any questions for anyone in our panel? All right, guys. Well, no further questions. I'm going to let him finish up.
See, that woke you up. You're welcome. You're welcome. I didn't even need alcohol to wake you up for that one. I'll let Roni do it for you. Are you sure you have no questions? Really? They were just that good? Oh, you got, what the? I don't know about the last one. I don't know. I trained him, so I don't. The only reason he's good is because of me. That's what I have to say with it. No. All right, so you've come to the end of the day, and you stayed awake and survived. So what do you think? Yay or nay? Yay. Oh, yeah. So should we do it again next year? Oh, man. All right, I'm done. We're good. Go home. We're good. All right. Well, this is, like I told you before when we started this one, this is all for you, right? I mean, this education, and we have people like these folks here. I got a chance to work with them and do stuff, and they come here voluntarily and teach. All right. So I think this is going to be a meeting that we are hoping to get bigger. Hopefully, we're going to have a virtual component to it next year also. So you don't necessarily have to drive here. You can actually do it virtual. However, I prefer you here. It's more fun. And you get food. That's a big thing, too. And then happy hour is going to be here in like a half hour. And you get free drinks. Just don't drive. Oh, Dr. Horn's back there, too. Anyone have any questions for Dr. Horn? Yeah, see, no one cares about you. You're okay. You're fine. You're fine. But so just recap real quick. After this, I'm hoping by next week or so, I will send you guys all the post-course survey. And then within 30 days, you're going to get the CME stuff. And then you will get the slides, right? I'll PDF them, so you all will get the slides. The only one due to proprietary stuff is Dr. Lowitz. Oh, actually, no, I don't have to worry about that one. No, don't worry about that one. All of them, I can give you a PDF copy of it. So you probably get like a Google Drive link that you guys can just download the PDFs and do what you like with it, okay? And you all have the emails, all right? So you have focus your email. Any questions concerning anything you all have? If you have questions about patient stuff, whatever it is, you want to have a certain provider or whatever it is, we're here. All right, I mean, our goal is a support system over here for you all. But if there's no further things or anything like that, happy hour will be, what time is it now? Around the clock here. 5:05, 5:30. Happy hour is going to be, I lied. Hold on. We're going to take a big group picture of everybody with it. The nice thing is you don't have to move. You just sit in your chair and smile. Because Roni's going to do it from the front of the room. How it's going to work, I have no idea. So if you want to fix your hair, makeup, floss, if you want to do something with your head, up to you. Whatever you're going to do, shine it up, do whatever you got to do. I'm okay with it, whatever you got to do. It's already shiny? Oh, even better, so it's already shiny. We're good to go with that one. All right, so after the picture, happy hour. Happy hour is going to be, if you don't know where it is, it's going to be in the ranch room. So essentially, you literally just go, like you're going towards the front. So you can go the side way here. Just go all the way to the front, and you'll see it looks like a little smaller ranch with that one. So happy hour is going to be included inside there. There's going to be some food there too. So hopefully we get to see many of you there. Okay, don't drink and drive. I have to be cautious about that one. That's my plea. Don't call me from jail. I'll ignore you. You can actually call Dr. Supermanian. I'll give you his cell phone number.
No.
Yeah, he'll come pick you up and bail you out. He's rich. There. All right, how do you want to do the picture? All right, he'll direct you. Let him direct you.
You to the back of the room, please.
I go to the back. Oh, I had to go to the back of the room.
Yeah,
Okay.
go to the back.
Yeah, they're going to come too, right? They're gonna
Yeah,
come too.
all
Okay,
of
good.
them.
Everyone's going to come back to the room.
So presenters, please go to the back of the room with Dr. Patel. For everybody else, I'll give you about 30 seconds. I'm a military man for makeup and hair fluff and whatever you want to do. I would prefer no water bottles on the table, Pepsi bottles, all that other good stuff. I also get the privilege of being Dr. Patel's GI nurse, so I'm not just the AV guy in the back, but 13-year GI nurse as well. So I happen to do all this stuff on the side because it's my side hustle, all right? So again, we're just gonna take one big group shot. So your biggest end of day smiles, please. I know it's been a long day. Trust me, I've sat through many of these myself, so I feel your pain, all right? So we're gonna do a big group APP. That means don't worry, it's not ER, so if I fall, I know I'm in bad shape, all right? All right, big GI smile, here we go. And happy hour, there you go, thank you. Yeah.